Hello again, everyone. We are almost finishing the second day of lectures, and I really hope you are getting the most out of it. Now, it's time to go back to South America to meet a special dentist and a friend, Dr. German Albertini, that for the past years has been developing all of his professional path around oral rehabilitation and occlusion. Dr. Albertini is a specialist in prosthodontics by the University of Buenos Aires, where he kept a faculty position as well in this area of study. German is also a national and international speaker, representing his country in the most important congresses worldwide. He has also been publishing articles in this field not only in his country but internationally as well. German is a member of the study and investigation group ABC, together with his fellows Dr. Diego Bekele and Aníbal Capusotto. Dr. Albertini will share with the world his presentation about integrating aesthetics and occlusion in adhesive oral rehabilitation. I'm really looking forward to watch him. I hope you like it.
Hi, I'm Germán Albertini. Here I am with Diego, my friend and partner.
Hi, I'm Diego Bekele. We are from South America. We live in Argentina, at the bottom of our continent. We live in Buenos Aires, our capital city. And we are speaking on behalf of the ABC study group. We are a team of 3 friends that 12 years ago started this project with the aim of sharing our experiences, our knowledge, and the same passion for restorative dentistry. Our friend Aníbal Capusotto couldn't be here, but he is part of all the work we are going to share with you in this lecture. In our beginning, we really never imagined that later on we will be sharing our philosophy with friends, with colleagues, with many masters all over the world. And it's really an honor for us to be part of this innovative event. And we really appreciate your kind invitation, Joao and Rui, to be part of this.
So, our presentation topic will be how to integrate aesthetics and occlusion in adhesive oral rehabilitation. Surely, we all are looking for predictable outcomes and long-lasting results in our ceramic rehabilitations. But what we should know is that are many factors affecting the outcome in complex cases.
Mm-hmm.
So essentially, any successful result are based on these 4 aspects. At the top are those related to the short-term results, while at the bottom we have those related with the long-term results. So the initial goals will depend on aesthetics and functional parameters, and are mainly based on the patient's acceptance of the aesthetic characteristics like color, textures, shapes, size of our final restorations. But there is a certain risk when these general aesthetic parameters meets patient subjectivity. That's why we have to have aesthetic analysis and communication with the patient.
Yeah.
The second aspect are the functional parameters, like swallowing, related to chewing, like to phonetics. But we have to highlight that in these 3 functions of the oral system, there's almost no contact between teeth. So with these 2 first pillars, we can consequently or indirectly produce emotional changes that influence in personality and even extreme social and life changes. This gratifies us and represents an invaluable feedback for our daily work.
Yeah.
But which are the factors that influence long-term results? Or which are the most usual complications in ceramics? So literature divides ceramic FDP's complications into biological and technical.
Yeah.
In terms of prevalence, there is an agreement that the most common complications are the technical, not the biological.
Yeah. And if we go in deeper into the concept of technical complications, core fractures and ceramic chipping are most frequent instead of other complications. But I want to make a stop here because these complications are well described and even well categorized, but what literature doesn't describe certainly is the etiology of such technical complications. Some studies have reported an association between fracture and parafunctional habits, and as a consequence, a greater survival rate in non-parafunctional patients. So we can consider that occlusion has a fundamental role in generating physiological or pathological forces to our restoration.
This becomes vital when we are dealing with bruxism. So most publications related to loading fracture of ceramic restorations are designed under compressive resistance in vitro, similar to clenching in boxers. For instance, monolithic lithium disilicate of 1.2 millimeters of occlusal thickness restorations had a mean value of 1500 newtons, and maximum voluntary bite force at the first molar area is approximately 700 newtons.
Less than a half.
So we can assume that adhesive ceramic restorations have enough resistance to support compressive forces. But laboratory in vitro studies represent a good simulation of what happens at the clinical level. What about the dynamic loading during lateral movements, as in grinding?
The issue is the following. In a masticatory system, there are much more than compressive forces. Occlusal contact forces are complex and unpredictable. During function, muscles are controlled by CNS to produce adequate biting forces for chewing, etc. This control disappears during sleep, and this unconscious state can potentially cause occlusal overloads with random directions and higher magnitude. So, the most dangerous contacts are those between cusps during lateral movements in posterior region. These forces are called flexural, and in general, ceramics are much less resistant to these forces in comparison with the compressive ones. Sometimes these uncontrolled forces may erode, may move, and even fracture natural tooth.
As we clearly see in this case. Imagine what would happen with our restorations, implants, ceramics, whatever. The best way to avoid this kind of contacts in posteriors is to provide the system with good anterior guidance. We will talk about this concept later, no?
Okay.
So, precision of our restorations are directly related to the biological result, but also occlusion, through the management and distribution of the occlusal forces. If we know about occlusion, we can do that, and is also related to the longevity of our restorations. But specifically in adhesive restorations, the technical complications could be divided into those that are related to the selection of the restorative material, the adhesive protocol, and also the occlusion. We are going to focus in the last group. You have noticed that we differentiate function from occlusion. Occlusion is much more than simple contact between the teeth or the upper and lower jaw. It involves static and dynamic relationship of teeth, joints, ligaments, muscles, and also the central nervous system. it is very important for us to understand these relationships.
You usually ask your students in every course that if they would make veneers in this type of cases, and the students say no. But we think that the problem is not the type of restoration, but what is important is to think partially or totally when you approach to these kind of problems.
In these cases, we have made veneers.
Yeah.
But we also make substantial changes in the occlusion through an integral approach. Veneers are an excellent conservative option in oral rehabilitation, but must be part of an integral treatment.
Can you show me what you have done?
We have done. We have to have an holistic view of the oral system. So here we have a case in which sometimes, if you decide to face such cases with a partial treatment, like ceramic veneers, probably you may have predictable problems. We don't have to underestimate the occlusion and its role in defining success or failure of our work. As can you see here, occlusion and diagnosis are very important because you can see single symptoms of pathologies, occlusal pathologies. Like here, we can say multiple abfractions, posterior crossbite, edge to edge, and we have to ask if it's a real class 3 or not.
So this is not a situation where the patient is prepared for parafunction. So parafunction will destroy much more this kind of mouth than other situation when the patient has this possibility of controlling the parafunction.
Yes. The important thing is that here we don't have to treat partially. Okay? You have to work with integrity. We have to work with vertical dimension. We have to work with the protocol. We are going to see all complete properly. We can work with ceramics, with adhesive ceramics, but working all complete properly. So our profession as any science is subject to constant change because of technology, and the aesthetic parameters are also undergo, as you know. But we have to think that biology and occlusion, they are not going to change in the near future. They are very important for us, for our profession is the basis, and for our profession is the basis, and
So we have to handle many items, and each one has an influence. We talk about hours about this. We talk about hours about this. But we would like to transmit is actually a philosophy based on a holistic view of the stomatomatic system.
A philosophy that will allow us to improve our treatments regardless of the material used. And this philosophy that we have learned from our mentors, Dr. Aníbal Alonso, and our fathers, Jorge and Alberto, through their clinical and teaching practice and exposed in a book that was called Occlusion and Diagnosis in Oral Rehabilitation, published in Latin America and also in Spain. And they show us this kind of work or the philosophy to work not with the materials, with the knowledge of occlusion. When they treat patients with severe dental wear in a time prior to implant or veneers or metal-free ceramics, restorative dentistry was focused on occlusion. Also respecting biological behavior in preparations and restorations, and finally, as a result of that, achieving an acceptable aesthetic outcome. It's our belief that when you respect anatomy, curves and planes,
three-dimensional alignment,
vertical dimension, among other issues, surely you will be indirectly positioning the teeth in the right place with respect to the face. So, in spite of not having all the current technical and digital elements that we have nowadays,
Yes.
the satisfactory aesthetic outcomes were achieved. But what about the long-term results of these cases? Do you consider the current or future materials will behave in the same way as those classic ones? We still don't know, maybe.
No.
Our personal opinion regarding restorative dentistry is, irrespectively the materials you have chosen, being precise allows you to be more conservative, because you also can change the crowns today. 30 years later, you don't have to go for implants here.
Yeah.
So when you are precise, you are being conservative. And when aluminas appear,
yes, there was an express contraindication to use them in parafunctional patients. But relying protocols based on respect for occlusion and understanding the management of this pathology, we used layered high-strength ceramic cores, and we have good results. Despite of not being adhered, these glass-reinforced ceramics allowed us to make more conservative preparations by eliminating the metal core, and that was the first attempt in being conservative and to avoid metallic frameworks. And again, also getting satisfactory long-term result, like in this case, where we can appreciate a very stable behavior after 20 years of function.
Such preliminary results allow us to strengthen our skills and to continue treating this kind of patients with metal-free ceramics. CAD-CAM systems appeared like Procera and created densely sintered alumina coatings to be layered with ceramics. That also showed us very good results in long term in many cases. There are some complications always we have when you work, but in generality we have a very good result.
Yeah.
Okay. As a matter of these facts, we should always include in our periodontal maintenance radiographic and occlusal analysis, not only clinically of our disclusion and occlusion states, also with the occlusal splint. That is very important. So we know that we are not going to stop bruxism. But what happens when bruxism? But what happens when new materials like zirconia? We started using them. And
with the same philosophy. The occlusion was present since the diagnosis phase, during planning, during treatment, during control, during laboratory procedures, and we also obtained encouraging results with the zirconium couplings.
So, but which is the key or the secret here is there's no, maybe our philosophy is based on occlusion and anatomy and trying to imitate the nature.
Yeah.
So, what is anatomy for? Aesthetics, function? Our occlusion school is based in trying to understand and imitate nature. Basically, we have two groups of teeth anatomically and functionally different. According to this concept of mutually protected occlusion, illustrate the role of each group. No?
Yeah.
During occlusion, the posterior teeth protects the anterior supporting the occlusal loads. And during lateral or eccentric movements of the mandible, the anterior teeth are in charge of the exclude the posteriors, no? Because they are anatomically and functionally prepared for that. No?
Okay.
So, you know that in literature there are some authors that consider the possibility of reducing the cost of the height of the posterior teeth. We strongly disagree with such idea because with an optimal posterior three-dimensional alignment and an efficient anterior guidance, those cubes can disocclude and you don't lose function.
So you provide the correct anatomy to the restoration, but you are aware of delivering a good anterior guidance that protects posteriors. That's what happened in nature.
In this beautiful photo of our friend Carlos Ayala, we appreciate the 4 levels of occlusion from the deepest fossa to the top of the cusp. They must be present in our ceramic restorations or any kind of restoration.
Yes, we don't create a new anatomy for restoration. It's the natural anatomy that will be or must be a goal to be reproduced in our restoration.
Mhm.
Yes, this determines functional characteristics with a good proportion between the occlusal components.
Mhm. So, we believe that one of the most important strategies for protect ceramic restoration is trying to give good occlusal conditions to our full rehabilitations.
As a didactic exercise, we should imagine the cusp as spheres. So, 2 rounded surfaces contact exclusively in a single point, and any lateral movement of any cusp will separate each other immediately. So, this is the mechanical principle used to obtain disocclusion of posterior teeth. So, depressions on tooth anatomy are in coherence with this concept. The direction of the grooves and fossas facilitates the escape of the cusp during disocclusion. Therefore, the occlusal anatomy that we provide to our restoration has a functional and also parafunctional objectives.
Also, the free full alignment is maybe one of the most important concepts in occlusion because it will let the anterior guidance to work properly. If the posterior teeth are well aligned in the correct position, it will be more easily for the anterior guidance to disclude them. For example, when the curve of Wilson is strong, the inclination of the occlusal guidance decreases and molars comes to disocclusion more easily at the gradient moment. So this should be our final goal, a mutually protective occlusion in which posterior teeth protects anteriors during closure of the mandible and anteriors protects the posteriors during lateral movements.
But it must run parallel with aesthetic.
Always.
Because the patients are not worried about curves.
The patient doesn't know about occlusion.
Exactly.
Maybe
they want healthy teeth. They want to a good appearance, good aesthetic behavior,
and long lasting.
Yes.
We can see that in our experience with cemented ceramic restorations have been promising.
Yeah.
But what we should emphasize is that we always use the same philosophy as we learn with our mentors.
So we use different materials than our fathers. We face different situations, but we still conserve this philosophy.
The materials change, the fundamental bases are those that last in time.
Yeah.
So what happens when we could use ceramic, adhesive ceramics, became another alternative for this type of patients. It was a true revolution. It is nowadays because we have new terms, new materials, new protocols.
Yes.
New preparations. In this way, this allow us to satisfy in general the demands of our patients in regard not only to aesthetics or minimum intervention, also in time, in simplicity, and the possibility of being really conservative. We are living a time of a real additive restorative dentistry.
So adhesive and additive, both concepts are stick together.
Allowing us to work with small restorations that can produce substantial changes in the interocclusal relationship and also in facial outcomes.
Exactly.
Changes.
But you have to be precise because we have to redefine the occlusal contacts. We have to recreate the space, and we don't have much space to adjust like we used to.
No, you have to be so precise. You don't have a space for problems to adjust problems at final. So
yes.
we are going to talk about it, a protocol that led us to be predictable in this. And it's based on occlusion. Occlusion must be present during all phases of treatment. It starts at the beginning in the diagnosis, where we have to look for signs and symptoms of pathology, occlusal pathologies. We have to see the dynamic of the mandibular relations. We have to see the discrepancies between CRO and MIP. And well, it continues with planning, where we have to go for the WhatsApp, and we have to define many issues, very important issues.
We do WhatsApp with occlusion in mind. Then we transfer this WhatsApp into mock-ups, into temporary adhesive restoration, and after that we go for the preparations to the definitive restoration and having occlusion in mind.
Always. We have to define many important issues like vertical dimension, position of treatment, therapeutic position. But during the treatment, you have to control that in the temporary adhesive protocol. We are going to see this new technique in the provisionals, and it has to be maintained and respect in the definitive restorations. So, but this doesn't finish here. We have to control this kind of patients with bruxism all life, and in the controls we have to also make an analysis of the occlusion of the occlusal splint. And well, to treat this kind of patients you are seeing in this picture that has destroyed almost all the teeth, his teeth.
Our objectives is to combine, to unify these two concepts, the aesthetic and the occlusion, as the strong pillars of our treatment.
So we have to put aesthetic first.
How to begin?
We have to put aesthetic first. Frank Spear
What's the
tells
first
us
step?
begin with aesthetics in mind, and we agree with that. It's the easy way, because you are going to analyze the face, the tensiolabial, and then the gingival, and then we are going for occlusal. So
can we sum up this concept with two phrases?
Yes.
Aesthetically guided.
Yes, like Spear, similar like Spear. The name call it is aesthetically guided, but we consolidated protected.
Oh, protected.
For us,
Okay.
It's a little change that we have made.
Sounds good. Yeah.
So, well, we have to see that we have to start with a very precise aesthetic analysis. All nowadays in restorative dentistry, this is very common. We have to first, like Gary Gurel says very well, we have to emphasize with the patient and see his requirements, try to understand him. Then we can go for the photograph and video documentation.
Recording, yeah.
And the facial, dental-gingival analysis, and we can use nowadays, the digital design. So
before focus our attention on tooth, it's mandatory to evaluate the elements that creates the facial composition, the frame of our work. So our target is to establish at the first step a proper parallelism between the occlusal plane and the horizontal references, and the ideal height of the lower third. After that, we move forward to the dental-labial analysis that includes 3 different situations: closed lips, rest position, and smile analysis. Then we go interally. So we start our static and dynamic occlusal analysis, where we look for signs and symptoms of occlusal pathologies. Here we can observe, for instance, the great loss of tooth structure produced by attrition, and dental wear gives us information about how the patient grins. This kind of wear anatomy is called the inverted Wilson, in which the supporting cusps of posteriors wear out more faster than the non-supporting cusp, because they contact both directions. And obviously this can happen when you don't have an effective anterior guidance.
Or it was destroyed in early stages of
already destroyed.
Of
exactly.
Okay. So after clinical examination, we have to start our complementary exams. There will be several issues starting from the beginning, like we have to relate the motors in a semi-adjustable articulator, and we have to decide in which position we are going to relate them. We have to decide which deprogramming device we are going to use, and there's many schools all over the world about occlusion. That is a very conflicted topic, but there is an amount of different opinions between each of these steps. So we have to we can show our philosophy that is based scientifically and clinically, but well, we have to decide, and every clinician every day have to decide this, and couldn't get into the confusion. No, we have to start working. So we are going to show you what we do. The first step will be mounting cast in a semi-adjustable articulator. Why we mount on 0? Because we understand that centric relation therapeutic occlusion that we can obtain in repeatable therapeutic occlusion that we can obtain in repeatable therapeutic occlusion that we can obtain in repeatable ways and a practical way during all phases of treatment. All phases of treatment. Devices such as leaf gauge or Ludia jig are simple and practical for getting the intermaxillar bite record in 0. Now we have all the information needed to mount our models. At this point, with the mounting cast in a semi-adjustable articulator, we are ready to begin our workshop. And we have to make a stop here and think that the original anatomical and occlusal parameters or characteristics of our patient has been lost. So technicians have to decide about many fundamental factors such as thought shape, thought axis, subsize, incisal edge position, curves and planes, vertical dimension, type of disocclusion, among other factors. So how to guide the technician in fabricating the workshop. The first pillar that we use in our philosophy is that we first establish the anterior relations for many reasons. They are well explained in an article published in 1969 by Scholler, who describes the advantages of establishing the anterior relation first. You can satisfy the aesthetic and phonetic parameters more easily, and you have the opportunity of using the anterior contact of canines as a natural jig to stabilize the mandible and help capture the CRO in a practical way, and also facilitating changes to the subsequent restorations. If you start with the posterior, sometimes you finish with the anteriors and you do short or longer restoration.
Much more.
And you don't know if the patients will accept that.
You could run under a risk that it will be minimal. It will be minimal. It's our protocol to simplify these complex cases by dividing the mouth in 4 sectors. Each sector has its own function. First of all, the sector number 1, upper anterior, that define the aesthetic and phonetic parameters. Sector 2, that is lower anterior, establish the centric relation and the vertical dimension. As soon as you bilateral canines. Sector 3, that is the lower posterior, used to design curves and 3D alignment. And finally, sector 4, upper posterior, that consolidates the interocclusal relationship. And we are going to apply this protocol during all phases of treatment because it allows us to control to control occlusion in a simple and a practical way.
So the most important teeth in sector 1 are the central incisors. So it will, if we going for his to reconstruct first that anatomy, it will give us or let us to get aesthetics, as we said, phonetics, by taking as a starting point the incisal edge of this. So we are looking for the incisal edge of the centrals.
And it's a very dynamic concept, how to locate this central incisor. I mean, you can see in the literature that at the age of 30, for instance, the mean exposure of the upper central incisor are approximately 3.4 millimeters and 0.5 on the lower. But over time, maybe at the age on the lower. But over time, maybe at the age and tooth length, the mean exposure of the upper central incisor are almost 0, and at the lower, almost 3 millimeters.
And it's changed or determined by age, by
there are many factors,
man or woman,
even even the gender. Yes.
Okay,
exactly.
So we have a protocol. We want to determine this length with the patient, and we can do it directly with a composite. You know, not adhesive composite, but directly in the first visit. Or we can do it indirectly with the previous wax-up and a mock-up technique, or we can use the digital with the previous wax-up and a mock-up. And then
based on the digital design.
But it's important before starting our wax-up to determine this factor. It's very important. So once we have found the incisal edge, we seek the gingival.
So you take the smile line and the anatomical proportion as a reference.
So we have here the incisal edge.
So exactly, we look at the rest, the lips at rest, and we establish the incisal edge position. After that, we go for the width and length of the anterior superior central, but it is under smile movement. After that, the third step is to establish the upper anterior incisal line defined by the lower lip. So we establish all the group in connection with the lower lip.
The incisal edges of the anterior superior.
Exactly, all the group, all the anteriors. After that, the incisal edge, the gingival line during smile.
By the upper lip, no?
Exactly, guided by the upper lip.
So now we have made our aesthetic analysis, and we have to join this with function or anatomical proportions in an wax-up. So we can transfer this info to the lab to be precise in the length of the most important part of the mouth, that is the upper anterior teeth.
So this step determines the whole work that will be done, first of all in wax, after that on provisional, and then on ceramic restoration.
So we can use also anatomical proportion to help us, and it's very useful. This formula described by Dr. Chu.
Stephen Chu.
You have the size of the uppers central, you can determine the anatomy of the upper and lower anterior teeth, and then we can also wax the rest of the upper anterior teeth, also
and transfer to
in the lower. And at this point we have bilateral contact of canines. This is very important because it increases the vertical dimension, and well, it also gives us our, as we said, the treatment position, the 0. No? You must analyze here at this point if the posterior interocclusal spaces are adequate for future posterior wax-up. If not, we have to decide the more suitable decision modifying the initial review by adding wax or not in the canines. So
after that, we go to the sector number 3. As we said, posterior on the lower jaw. And we can see the planes, the curves, and it's very important to give a 3D full alignment according to the sagittal and frontal curves. And one more time, we check for space, for a good space, and to if we have sufficient space for
The last
recreating
sector,
exactly
the anatomical characteristics of the upper posterior.
Exactly.
That
is the sector number 4.
It is the sector that it will consolidate the occlusion,
Yeah.
the interocclusal contacts, and we must finish our wax up with this, basically with a stabilized occlusion, by the, supported by the posterior and with a slight contact in the canines and with this occlusion. But it is important to remember that the incisors that doesn't have to contact in occlusion. It had to have a slight contact, but this had to have a slight contact, but the most important contacts must be in the posterior and the molars and premolars, because they are prepared for axial forces. And when we are defining the type of disclosure, we prefer the anterior guidance because versus the group function, because we think that we have many advantages, such as that they determine less electromyographic activity of the elevator muscles that are bigger, higher, and important. So we want to protect our restorations with this kind of disocclusion. So now we have a different part of the treatment. We can go for the clinical part.
Exactly. So we have 3 steps up to definitive restoration.
How do we continue from wax up?
We have different options and different steps to follow. In the current protocols, we add a new step that is called temporary adhesive protocol, where we create a functional mock-up that it will help us in planning and to establish the new occlusal parameters, planning phase. So we have 3 different options, from the typical classical mock-up that it will be just 1 to 3 days and is very motivated for the patient, and we choose bisacrylic materials. This new temporary adhesive protocol that it will transfer the information from the wax up to the mouth, and it will last more or less from 6 months to 1 year, and it must be made by composite restoration because it will be under function. And the final option is the provisionals, that it will be used only for the time that the laboratory will prepare the ceramic final restoration, maybe 3 weeks, 4 weeks, it depends on how much time. And the chosen material is once again bisacrylic. So the first step is to duplicate the wax up into stone models, and after that to create some silicone indexes to transfer this information. You want to see a video?
Yes, sure.
Let's go on.
So, as you see in the video, it's a very practical way to analyze the parameters that we have obtained in a WhatsApp. We can analyze the aesthetic parameters. We can also analyze the vertical dimension and the profile. We can see that we are so used to change vertical dimension. For us, it's not a problem because we came from the restorative school with many materials. We make implants and all kind of prostheses. So vertical dimension is something that we are used to change, and it's very important because you can change the facial proportions and at the beginning. And as you can see in this case, in the mock-up stage, you can give a new appearance and a new self-esteem of the patients. We usually change in our patients, and it's the time also to see the occlusal parameters, the functional ones, not only in closure, also during protrusive and lateral movements. It's time to make the changes. If you decide it, you can go back and change the WhatsApp, but if it's all correct, you can go for the second step, that is the adhesive protocol. And you have to decide which material you are going to use, but it's always composite in its different situations. You can use composite resins, you can use preheated composite, or you can go for flowable. But you have to know that you have to use some composite that has the properties to be in mouth during months sometimes. I had the honor and the opportunity to help Dr. McLaren in a live course in Buenos Aires and see his famous technique of bonded functional aesthetic protocol. Here is the article. It's very useful. You can read it because it's a very good article for starting with this technique. As he explained in his publication, we have to make individual vacuum trays for the translucent silicone. But previously, we have to prepare the field for the adhesive protocol. We cannot leave any deficient restoration or cavities, so you have to take care of this. Now we can start our adhesive protocol by our systematization of the ABC study group, and we have to start for sector 1. So Diego, you can continue.
Yeah. As we said at the moment of WhatsApp, we have to be coherent with this idea. Once we establish the anterior superior tooth, we have to transfer this information to the lower jaw. And in the sector 2, we offer the same type of treatment to establish this vertical dimension, to establish the bilateral canines contact, and then to establish obviously the vertical dimension of occlusion and the eccentric relation. Once this step is controlled, we can go further. Contemporary materials and techniques are available, and then there can provide a cost-effective and conservative restorative alternative for patients. And maybe it's to be more friendly in an economical way, just to maintain this rehabilitation for a couple of months and not to force the patient to pay a very
viable solution
exactly
for some kind of patients.
Yes, sometimes to deliver 20 crowns or 20 veneers to the laboratory, it is very expensive, and sometimes it is a good option to continue with the treatment, to continue with your planning, and just stop maybe in a good moment.
But if you decide with the patient that it's the possibility to go to the final restorations, we have to go to the final restorations. We have how we are going to do it.
Yeah.
And here we have three options. You can go for a full mouth rehabilitation of the two arches. You can go for the two-step, one arch by time, or you can use the protocol that we prefer, that is the sector side, the 4-step, as we have made the wax up. We are going to show you some cases or how we do the final restorations by part, sector sides. We can finish, as you see in this case, the sector 1 and sector 2. And you maintain this is very practical for the technician, because you can maintain the occlusal parameters of the posteriors, and you don't have to prepare the posteriors and change the vertical dimension.
Yes.
That's something to prepare the posteriors and change the vertical dimension.
Yes.
That's something.
And it's a good way to minimize the possibility of errors in the tooth form, in the tooth shapes, in the location of the curves, to establish the right occlusion on posterior, because doing step by step, establishing first of all the vertical dimension, the centric relation, to establish the space for posteriors is very useful, and it's less time consuming for clinical time and for laboratory time as well.
So when we go for a sector-based protocol, you have the advantage, we said, of finishing the anterior restoration first. For the patient, it's better because it's the aesthetic part of the mouth and they have already finished it. You can establish the aesthetics, the phonetics, and also it becomes more viable from the economic point of view, because you can change 6 or 12 restorations, ceramic restorations. But now you can go for sector 3. You can go for sector 3, the lower posteriors.
And it's much more easier to establish the location of the curves, to establish a good tooth shape, the tooth anatomy, where will be better the cusps and all the anatomy that we were talking.
Remember that we have already the contact. Remember that we have already the bilateral contact of canines. So use any. What we think is that you don't have to use any programming device. No, the programming device. You can only put material in the posteriors and
record this position
and say the patient's close, and you have the bilateral contacts of canines, maintaining the vertical dimension, and putting your condyles in 0. So it's very simple, it's fast,
and it runs very smoothly. Yes, as you said.
You send all the info to the lab to make in this case, we have made monolithic lithium disilicate bone lice. Monolithic lithium disilicate bone lice. And when you have the sector 3 finished with these preparations and restorations, ceramic restorations, we can go for the last sector. And you can, again, after preparations, we have bilateral contact of canine, maintaining the vertical dimension, as we said, and we can analyze the space for the future restoration if you have to prepare more
or less. Yeah.
Or less. We take the bite registration without any deprogramming device and send to the laboratory all the data for the last sector, that is sector 4. As you see, you can do monolithic. And after cementation, you have the final view of this adhesive rehabilitation. And as we said, we have to have occlusion, and we have to have disocclusion.
Of course.
With the canine guidance. Remember that disocclusion of the canines have to give posterior spaces. You will have less space in the working side, that is the side that the mandible goes, and more space between the posterior teeth in the contralateral side. So,
you did a great job, eh?
Thank you, Dio. But well, you can see the final aesthetic analysis at rest position during smile, and the great changes that we can give to our patients with this kind of ceramic restorations, with all the advantages that they have.
But we have to protect, no?
Yes. So
an outward, instead of giving the patient all the parameters and all the protection that the tooth has, we have to be careful on
you
this.
Have here,
and it's like an insurance.
Yes, it's an insurance. We have to highlight three items. First, we know that we are not to stop the bruxism.
Yeah.
We have to protect our restorations by occlusal splint. First, we have to have a very good patient. We have to have patient awareness.
Yes. Committed with
very important
with their job. Yeah.
And we have to have continuous controls. Maybe six months.
Yeah. Because we cannot stop bruxism.
All life we have to continuously control by periodontal maintenance, the occlusal splint control, and see clinically if we have some signs or symptoms that he is not using the occlusal splint, or maybe his bruxism, he has parafunctional habits during the day.
Yep.
No? So, but we have sometimes young patients, and we use a different approach, more conservative approach.
Yeah.
There's a lot of young patients by erosive or attrition, as you know. We use different protocols as like bilateral sandwich technique, and we are going to show you a case like
because
this.
the challenges are much more important.
Mm-hmm.
I mean, if you treat a patient with a 30 years old, a 25 years old patient with a general erosion in their mouths, so our movements should be very conservative, thinking that this kind of restoration will be in contact for many years. You have to change your mind in comparison with a 60 or 70-year-old patient that will receive her first or his first rehabilitation.
You are giving the possibility in the future for new technologies.
Absolutely.
And the possibility of your patient to get less gradient restoration.
Therapeutic gradient, yeah.
Okay, but at this point we are going to show you how we treat this kind of patients with our sectorized protocol. We call it the 4-step technique, because we are going to use the same as we have shown before during the wax-up, during the adhesive systematization, and the definitives. When we treat young patients, we start by the anteriors, and for the bilateral contacts of canines, we prefer to work in the upper with the palatal veneers, this kind of resin. We are going to adhere them, and in the lower we have done direct composites, because it was a very little loss of anatomy in this kind of patients. When we have this upper and lower anatomy restored, we again have
We established vertical
the
dimension,
vertical dimension, the
centric
zero.
occlusion, exactly.
By the bilateral contacts of canines, the anterior, the incisors doesn't have to contact at this stage. Remember that. And we are going to analyze at this moment the posterior spaces.
Yep.
We go for direct composites in the premolars because it's usually a teeth that doesn't
Should
have
be more
much,
conservative,
yes, much wear. But in the posteriors, like in the first molar, we sometimes have very
aggressive
yes.
loss of
Uh-huh.
tooth structure. Imagine that this first molar appears at the age of 6,
Mhm.
and
This-
is the first molar in the mouth.
Mhm.
So
These young patients
have suffered many years.
starts bruxism
exactly.
at
that age.
At
yeah.
that age. So well, at this moment we have to put some material for our bite registration and send to the lab to make this kind of restoration that are tabletops.
Yep.
They are not boneless. They are very conservative. You are only adding ceramic material
the tooth
to
structure that you have lost.
Uh-huh. So, as you see,
So
here we have the
different designs
different
for
designs.
different laws.
Mhm.
No?
Different design, different laws, and different preparations.
Yeah.
And we, in this kind of patients, always want the more conservative, that is
Yeah.
the additive way. But when the patient doesn't like his color, or you have some in vestibular, some lesions,
Yeah.
cervical lesions, you can go for a bone light.
So you cover not only the crucial surface, but the facial
Uh-huh.
aspect of the tooth.
So, as you can see,
Very
we
thin,
are,
no?
yes, ceramic restorations nowadays in disilicate allow us to have very, very little
Yes, very thin restoration,
very thin restorations.
just to recover only the tooth structure that you have lost.
So, after adhesion of these restorations is when they biomimetically and supported by the dentin and the enamel,
Mhm.
they're going to get strengthened more high, no?
Yeah, they are very fragile
Mhm.
on the model,
Mhm.
but once you do your adhesive protocol, it becomes like a unit
Mhm.
on the structure of the tooth and the restoration.
Okay, so here we have to go for the last sector, and as you can see in this picture, we have 12 adhesive restorations, additive restorations in the upper jaw, and we have still go for the vestibular part
Yes.
of the upper anteriors, the sandwich technique. And here you see the ceramic restorations we prefer in this part of the aesthetic zone. The final result in this case, and a pre and post adhesive oral rehabilitation in these cases, a conservative approach.
And one more time.
Protection,
Yeah.
we can stop bruxism. And as you see in this article, that suggests the use of canal guidance also in the occlusal splint, because in lateral occlusion, for therapy will full coverage of occlusal splint, because the lower, almost again. We have our final rehabilitation, the pre and post view.
And one more time.
The occlusal splint, we cannot stop bruxism.
Yep.
And we also use the Canon guidance in this occlusal splint, as you say in this publication, for lower electromyographic activity of the elevator muscles.
Yeah.
So
extraorally, you can see
mhm.
the impact, no, of the treatment. the vertical dimension, aesthetics, and
Mhm.
many facial aesthetic parameters that have changed.
So we are going to share with you another case in which we are going for another protocol or another approach, that is the one arch by time, and we are going to use the temporary adhesive protocol as a guide for our preparations, as Gali Gurel published in Veneers, or Mauro Fradiani have published with MIPT technique for minimally invasive procedures in prosthetic. So you can see here that we have transfer, yes, or we have the guides for our deep preparation. We are going for boneless.
No?
Yes,
you have to choose the which kind of restoration is more suitable for the case.
Yes, in this case, the patient wants to change the color of all the rehabilitation, all the teeth. So we are going to prepare for boneless in this case. As you can see here, we have prepared the deep of our preparations in vestibular and in occlusal.
And it's very important to know that most of the preparation is done over composite and not over tooth structure. So you are not losing much more tooth structure. You just quit the little amount of tooth structure that you need to place the future restoration.
So you will have here some parts of enamel, dentin, and resin composite that we are going to leave of the temporary systematization
under the restoration. Yeah. But there is an important point.
Yes,
at
sure.
This moment, no?
This is very important because you have to remember, if you go for one arch technique, you have to take care of, remember to take bite registration before you touch the canines, as you see in this picture.
So in this protocol, we change the steps. So we prepare posterior, record the position, not to lose,
maintaining the bilateral contour of canines.
Exactly, not to lose all the information that we have transferred from the articulator.
The wax up to the adhesive systematization, and that the patient has be adapted to that. Before, during month, using this adhesive protocol.
But so one more time, we use the canines as a guidance for recording the position between each arc. So
once we have recorded, we can go for the anterior preparations, for in this case for veneers. We have all the lower arch prepared, and we have to see, we have all the info for the lab. Now we have the substrate color, we have the Facebook, the final impressions, the antagonist model, the zero bite, and the model of provisionals, if you want to.
From the WhatsApp,
So this, it's important, because once you have the models and the die cutting of the preparations, you have the technician have to decide the ceramic and the way for the anatomy. So we can go for digitally, but in this way we have made a mix, because we want to scan the analog wax up, because it was the individualized anatomical characteristics that we have made, and the patient had accepted. So we are not going to use the anatomy of the digital programs.
And it's easier for the technician to have this information that was primarily made at the moment of waxing.
And as you see here, it's incredible. You can see the parafunctional movements, the lateral movements digitally, and you can control that. Now we are going to well, to make the CAD/CAM preparations of the wax for the press technique.
Yeah, injection.
We are going to use the injection technique. We are going to use IMAX, lithium disilicate. So we are going for monolithic in the posteriors and some little layering of ceramics in the cutback in the anteriors. You can see here the beautiful anatomy of those teeth, posterior teeth.
Great job by the
laboratory, Argentinian laboratory, Nestor Louis. Well, here you can see a resume of this protocol. We have the analogic wax, the digital scan, the CAD/CAM wax, and then the press ceramic with
look at the coherence between all the steps. We started at that starting point with the wax. We respect this anatomy at the planning moment, at the temporary adhesive treatment, at the provisionals, and after all, we do it in the ceramic restorations.
Mm-hmm. So now we are prepared for adhesion, and we are working many times with very little thin restoration. Publications are showing us that the fracture resistance of adhesively elected non-retarded full coverage molar restorations made of lithium disilicate is promising and seems to permit clinical application. So we are working with very little
pieces of ceramic.
So here we can see that we maintain the occlusal anatomy as we said at the initial of this conference. We see that we can maintain the cusp height, the anatomy, because we are going to have an anterior guidance that it's going to disclude this posterior
teeth,
and protects them. So here you can see the general view of the lower arch restored and bioresume. You can see that in the posteriors we decided to do bone lines and the anterior veneers. This is an additive.
So you choose the design of the restoration depending on the magnitude of the tooth loss.
Mm-hmm.
So you customize your treatment, you customize your restoration for each tooth to be more conservative, to be more predictable.
Maybe 10 years ago or less or more, maybe I didn't approach this case
absolutely different
like this. So this is what adhesive restorative dentistry have made
changed,
in our protocols.
Absolutely.
So well, we have finished the lower, we can go for the upper. In the anterior teeth we decided to make, because of the age of the patient and some more things like cavities between in the proximal area, we decided to not go for the sandwich technique.
Mm-hmm.
We decided to make crowns, but with little preparations. We are going for vertical margin preps nowadays. This is a very little chamfer, but in the posteriors we decided to make bone-like preparations, and you can see that this is a very useful burr for for the posteriors in this kind of
preparation.
Yes, for other adhesive preparations. As you can see here, we have 3 different substrates to adhere. As you can see, we are going juxtagingival. We are working nowadays with loops and microscopes, so it is letting us to make this kind of preparations.
We use magnification to prepare the tooth, to take impressions, to cement. All the steps are critical, and it's necessary to be precise on each movement, and it's impossible to do it each of that steps without some kind of magnification.
Here we have three different types of substrates to adhere. We have enamel,
Yeah.
steel enamel. We have dentin, and we have resin composite. That
was used of part of our systematization.
And this is systematization. So, well, this is imagine a picture of the upper jaw, and we are analyzing the occlusion and the disocclusion. Here we have the upper restorations. You can see the anatomically respectful of the four levels of occlusion. Occlusion anatomy has been combined with 3D full alignment to permit the anterior guidance works with efficiency. And it is very important to see that we also have respectful for the posterior interocclusal relations.
And one benefit of this protocol when you treat a full arch restoration is that you have a perfect antagonist plane to deliver all the anatomy of posteriors.
Mm-hmm. So as you can see here, we respect the posterior contacts. Here you can see the contacts, the stoppers and equalizers, are the contacts that maintain the mesiodistal mandibular stability.
And how thin are these restorations?
0.3, 4.5 millimeters.
Okay. So, can you show me a picture?
Yes. As you can see here.
No.
Yes. At the margin, we have almost 0.3 millimeters. We are, as we said, we are going for no finishing line sometimes, also in crowns, and you need magnification for that. That is very important. But you can see here the final view of the enclosure, and you can see a view of the anterior guidance prepared with the anatomical characteristics to be prepared for disocclusion.
Yeah,
you have the marginal ridge,
eccentric movements. Yeah,
this is the palatal part of the anteriors. The upper anteriors is the functional one, not the aesthetic, but it's very important and not always respected by technicians or by dentists.
Yeah.
It is very important to make the marginal ridges. Well, here we can see the pre and post rehabilitation.
Look at the change in vertical dimension. Look at the change in the way that the upper and the lower jaw relate each other. How do you recover, and the impact of such changes in the facial aspect?
At rest, and your smile, and well, we have to remember that we have to get a stabilization of the mandible during closure through our occlusal contacts in the posterior region, and we also have to have an anterior guidance that disclude the posteriors to protect our ceramic restorations. As Lavigne and the group of Lavigne, that is one of the most important researchers about bruxism in the world. He says in an article that no definitive treatment strategies for eliminating sleep bruxism have yet been established. Thus, prosthodontists' main strategy is to reduce the effects of occlusal overload in the teeth and prosthesis in prosthodontic rehabilitation. And we think that occlusion is the key for that. In several reviews about the treatments that we have nowadays for sleep bruxisms says that there's no definitive treatment, so occlusal splint prevent undesirable consequences of bruxism in our restorations and teeth. So it's our treatment
So
of choice.
we create better conditions for the system to protect, but you cannot avoid
No.
the bruxism.
No, you can.
So
you have
still
to
be
live.
present in the future.
So we have to. Our strategy is to give occlusal conditions.
Mm-hmm.
If someday the patient doesn't use the
null
occlusal
board,
splint, he will have the anterior guidance prepared for
Yeah.
disclosure, and it has advantages from group of function, less overloads.
Mm-hmm.
So maybe we can have problems. We have complications in our rehabilitation, but we know that there will be maybe in the anterior
Mm-hmm.
sector first, and we have promising results if the patients are conscious and awareness.
Yes, and committed to this
this
protection.
objective.
Yeah, exactly.
Always the controls. The occlusal splint is very important for us because it generates organic occlusion.
Mm-hmm.
It reduces the muscles hyperactivity. It's more stable for the articular position and protects our ceramic restoration. So, in concluding, we can say, Diego, that the upper incisal edge protocol is very useful in its practical way to determine the aesthetical parameters.
But it's not only the aesthetics,
Mm-hmm.
as we said, no?
It has to be joined with function, with
Exactly.
occlusion. We have to maintain full structure as a precursor to more complex restorative options when required. So nowadays, the minimally invasive procedures
Mhm.
are a must. In restorative dentistry, we can use adhesive ceramics because they are an excellent alternative for restoring dental wear
Yes,
cases.
it revolutioned the restorative dentistry nowadays.
And it's published and it's demonstrated that they
Absolutely
can
sure,
be
yeah.
used in bruxism
Mhm.
patients. We have through occlusion, we can distribute effectively the occlusal contact and
Mhm.
help to reduce the overload in our restorations. And in the protocols, we have to decide for use simple and practical ones. No? As the ABC systematization, we think that is maybe a possibility for
Yeah,
us.
it's our proposal.
It's our proposal.
Yeah.
So, and finally, occlusion must be present since diagnosis to the final outcome, and even in the controls during all life. So we hope that you have joined this presentation, this lecture. We want to show you that a little video about the ABC study group. We want to continue in contact with you. It's a great opportunity to share our philosophy all over the world. So we can keep in contact and we will show you what we do in Buenos Aires. So,
Well, many thanks, Joao and Rui, for the kind invitation. one more time. I want to thank Aníbal Capusotto, our third part of our group, and Herman to share this lecture with you all, and I hope see you all around. So many thanks again.